Okay, hello everyone, and welcome to Venom Connections, bridging global insights and local solutions for snakebite and venoming. We were hoping to give it a couple of minutes for more people to join. As of now, we have over 100 people online. We had over 500 participants registering, and so we expect the numbers to pick up quickly. But so we don't lose time, we will start. This webinar is brought to you by the Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine in Ghana, in collaboration with the Global Health Network, Oxford University. Now, we convened this webinar to delve into the pressing issue of snakebite envenoming, which is a global health challenge that is often overlooked. But this is rapidly changing, obviously. Now, our agenda today spans an exploration of the global burden to examining regional and local initiatives. Although we have limited engagement time today, maybe an hour and a half, we'll try to spotlight the magnitude of this problem, the relevant policies and research and innovation works going on across the landscape using a couple of selected case studies. So our aim today is to foster knowledge, exchange, and then catalyze future collaborations. So thank you very much for joining us today. Just by way of introductions, my name is Melvin Abuwate, and I'm a clinician and researcher with GHID at KCCR, and I collaborate on several research projects, including clinical trials for infectious diseases, implementation research on non-communicable diseases, and I have a growing portfolio in snakebite envenoming. Currently, I'm working on a prospective study to clinically characterize snakebite envenoming in the Upper West region of Ghana. And I'm delighted today to be joined by four eminent panelists in the persons of Dr. Venom, who is at the BNITM Germany, Ms. Valentine Musabyimana at K-SRIC in Kenya, Dr. John Amoesi, also at KCCR in Ghana, and Mr. Tripathi Dhananjay, who is the CEO of Atlantic Life Sciences Limited in Ghana. I intend to introduce them a bit more in depth just before they speak, so you know what all those abbreviations mean. So that will follow shortly. And just a quick note on the agenda for the session. We'll have 4 presentations, each will last approximately 15 minutes. And our first panelist will be Dr. Venom, who will take understanding the global burden of snakebite envenoming, and this will look at the magnitude of the problem and some challenges that we face constantly while trying to address this. Then the second will focus on innovations in snakebite research and collaborations in Africa. This will be taken by Valentine. And then Dr. Amoesi will take us to snakebite research and policy. And finally, but certainly not the least, we'll look at some local solutions and manufacturing using a case study of snake antivenom manufacture in Ghana. Our expectation is that these presentations will deliver impactful knowledge and help us identify opportunities for collaborative research and innovation. We have a main Q&A session at the end, although as we proceed, we will be taking some questions in the chat, so feel free to use that as you see fit. And along the line, we will deploy a very short questionnaire, which will help us to get to know you better and how we can engage you further in the near future. Okay, now on to some housekeeping issues before we actually start presentation. First of all, the session is being recorded, and in the coming weeks, we will share this recording on the Global Health Network platform so that you can review this and also further share this material within your networks. And as we speak, the link to this is being shared in the chat, so you can save that for later. You can also use the chat feature to introduce yourself if you wish, or to report any technical issues you might be having. And the technical team will work behind the scenes to support you on this. You can also interact with the panel during the Q&A session. Of course, you can post your questions and comments, and you can do all of this anonymously if you wish. You would have noticed that your cameras and microphones are currently disabled by default due to the size of the call. But certainly at the end, there will be an opportunity to ask your questions verbally, in which case we will directly invite you to raise your hand, and then you'll be able to enable your microphone, and then we'll listen to you. We have about 20 to 30 minutes allocated for Q&A at the end, so we'll try to get through as many questions as possible. As of a few hours ago, this is the number, what you see on your screen is the number of participants who had registered, and we expect to be joining us today. Okay, great. I think I've more than adequately covered the essentials. So let's get straight into the thick of affairs. Whilst Dr. Benokoro starts sharing his screen. So I would like to introduce Dr. Proyles, who's taking the first topic on understanding the global burden of snakebite envenoming. Whilst he shares his screen, Venom is a physician and epidemiologist from Germany, and he currently leads the research group on snakebite envenoming at the Bernard Nock Institute for Tropical Medicine in Hamburg. He has about 20 years of experience in research in Ghana and Malawi. So although he's German, he has very solid African credentials, as you will see. So his research group mainly works on improving our understanding of the epidemiology of snakebite envenoming in Africa and improving treatment outcomes for victims of snakebite envenoming. The group currently has projects in Ghana, Malawi, Gabon, Sierra Leone, and the People's Democratic Republic of Laos, as well as Vietnam. Thank you very much for coming, Venom, and over to you, please.
Thank you, Melvin, for the introduction. I hope you can hear me, and I guess you can see my slides. Otherwise, please protest. First of all, I would like to...
you are audible when we see your slides.
Thank you. Thank you again for the invitation, John, Melvin, and the rest of the Global Health Network for inviting me to the panel and giving me the opportunity to speak here. So I will try to give you a brief introduction into why it's so difficult to understand the global burden of disease and why we still underestimate snakebite envenoming. And I'd like to start off with a very nice article, not a scientific article, but it's a reporter piece that was published on the Nature website in September last year, which with the headline, "More people die from venomous snake bites each year than have ever died from Ebola." And that is something that very many people I speak to don't really believe or don't realize, that Ebola, which is going up and down in the press all the time, is actually not as big a problem for a lot of people as snakebite is. And just to give you a brief pictorial introduction into what the magnitude of the problem is, we can have a look at how many people die of Ebola, for example, per month. It's estimated at 5,000 deaths per year. So this is 436 deaths per month. The same for Lassa fever. And if we look at snakebite, this is the pile of snakebite deaths we're actually dealing with worldwide. If we look at numbers that are cited on the WHO website, for example, we see 5.4 million snake bites annually, of which only half are by venomous snakes, and the deaths that are estimated lie somewhere at 125,000 deaths. And the disabilities go around 400,000. But as people who deal with statistics know, numbers that have 3 zeros at the end are probably not measured, they're estimated. And these estimates obviously rely on models and keep changing over time. So the big standard of estimating global disease burden is the Global Burden of Disease Study. And a paper came out last year that looked at snake bites as well, or actually it's 2 years ago now in 2022. And this study estimated that 63,400 people die of snake bites with an estimate uncertainty of 40,000 to about 80,000. Now, what is true, the 125,000 or the 63,000? We really don't know. There is a lot of uncertainty in this, but it is worth taking a closer look at this paper. And within this paper, we see a map of the world, which shows what the mortality rate, the age-standardized mortality rate in different countries around the world is. And you can see here that India is highly red and covers actually 40,000 of the 63,000 estimated deaths in this calculation. How can that be? Well, if we look at this in a bit more detail, you will see that there is a very lightly colored country just north of India, and people who know the geography of Asia know that that is Nepal. And Nepal here in this estimate seems to have a very low standardized mortality. So snakebite in Nepal here doesn't seem to be such a big problem. But another study that actually went into the communities in Nepal, and not in all regions, because in the highlands we don't have snakes and Nepal does get very high. But in the lowlands, they found standardized mortality rates, or mortality rates of up to over 100 per 100,000, and definitely somewhere between 0 and 20. And the overall estimate was around 20 for that region, 20 per 100,000, which is 3 times as high as the highest Indian estimates were in the modeled global burden of disease paper. So it seems that if you really go into the communities, the numbers are a lot higher. And we'll look at why this may be the case. So coming back to this paper, if we look at the underlying data that was used to model this, we immediately see that they used vital registries for some countries, they used verbal autopsies for some countries, and they used no data for a lot of other countries. So snakebite hotspots such as Nepal or Laos PDR and Cambodia, or actually the whole African continent, didn't contribute any data, and this was modeled. So the question is, how useful are models if they don't have any underlying data? And we really need to improve the underlying data. What we could do for that is use hospital data. Here, a press conference John held in 2020, I think it was, presenting that Ghana records about 9,600 snake bites per year. And then a subsequent publication that came out showing the distribution of those snake bites throughout Ghana. We realized that the Upper West region, where Melvin mentioned he's working on a clinical prospective characterization of the bites, seems to be a hotspot within Ghana, while obviously big cities like Kumasi and Accra don't record very many snake bites. So using hospital data is helpful because it helps us see the distribution. But there is a problem that is inherent to hospital data. We only record deaths that occur in hospital. And especially in snake bites, this may be an absolute underestimation. So here, if we look at a case of Savannah Ket in Laos, if we estimate the hospital incidence or the incidence based on hospital data, we end up with 4 bites per 100,000. This is not deaths, this is bites. And if we go into the community, this is more than 100-fold higher, and only less than 2% of the people who are bitten actually present in hospital. And the numbers are different in every region, but they are always an underrepresentation of what is going on in the community. And if we look at why this is the case, this is one of my favorite headlines from Malawi, from the Nyasa Times. There's a central hospital that ran out of antivenom, so they consulted a traditional healer instead, who was a hospital guard. And if you speak to people in hospitals, you often realize even healthcare workers would prefer going to traditional healers, because there's a very strong belief that snakes were sent by someone, and that traditional treatment should take care of them. And I really understand that well, because if you don't have adequate treatment in the hospital, why should you spend resources, time, and money to travel somewhere where you don't receive adequate treatment? And then obviously people consult traditional healers. So what can we do to improve this? We can do what we did in Gabon, go out into the community, ask people whether they had a snake bite, whether someone in the household died. And this is just without the results, showing that we actually had conducted a survey that involved 12,512 residents in over 2,900 households. So that's a huge amount of work that is put into a survey like this. And this is actually calculated to be able to estimate the bites and not the deaths. So huge community surveys would be necessary to actually estimate this death, the death rate in countries. It's good to have it from each country once, but it's not something you can do to estimate the burden over time. So what we should do somehow is improve the number of people attending hospitals. And how can we do that? Well, this is an example of Savannah Ket in Laos again, where my colleague Jörg has been active for a very long time. And the numbers in that hospital went up. So what is the secret to getting people to attend the hospital? What he did was he made sure there is antivenom in the hospital, and he trained the medical staff to be able to treat patients, and he put the word on the street that this was a new snakebite treatment center. So treatment is available for free by people who know what they're doing, and suddenly patients come and are willing to spend more time and resources to receive proper treatment. And then you can obviously easier measure the burden of disease while also reducing the number of deaths. Another problem that we have, and I would like to finish with this slide, is and recommend this paper, which is a journalist's piece in the BMJ from last year, looking at problems in global health. And if we look at going back to that global burden of disease study, who are the authors of that study? We see this graph here, and every author is a single column. So you see a lot of authors were on this paper, as you see on the x-axis. And on the y-axis, you see the number of publications these authors have. And there you see that the GBD collaboration papers they have authored are very many, while the snakebite papers that these authors have been involved with in yellow are very few. So hardly any experts were working on this paper that had any expertise in snakebites. And these three arrows represent the three African authors on this paper. So again, the African continent was completely ignored, which is a huge problem because we need to create this expertise in the countries where the burden is high. And this paper also looks at funding. When snakebite was made a neglected tropical disease, Wellcome Trust pledged a lot of money, several millions, I think up to 90 million. And this looks at where did this money go? And here you can see, without going into detail, that only a very small, this blue segment here of money went into countries that actually had snakebite, and a lot was left in Europe and the US. Again, a problem of distribution of funds as well as expertise. With that, I would like to finish and hand over to the next presenter. Thank you very much for listening. If you have any questions, please get in touch by email, follow us on Twitter. And finally, one more thing I would like to ask a favor of everyone listening here. We try to create events where we connect the global community, have interdisciplinary discussions on snakebite. Last year, we had a summer school in Hamburg with over 100 participants from over 40 countries. And we would like to hear your opinion on what kind of events would be useful for you. Please scan the QR code, or Melvin will post the link to that questionnaire in the chat. And you can also leave your email there if you would like to hear about events that we host at BNITM. Thank you very much.
Thank you very much, Benno, for that insightful approach to what I would say could otherwise have been very boring data, as it is for most people who are not snakebite insiders. I mean, I have been really illuminated from this. To the audience, please feel free to post your questions or comments in the chat box, and Benno will respond to as many of them as possible once I forward those to him. But just before I leave Benno to take care of that, I'll fire just one salvo at him as we segue into the next presentation by Valentin. Benno, many people believe that the burden of snakebite is underestimated due to underreporting and other health system factors. I also am aligned with that kind of thinking. But for others, they think the case for snakebite may possibly be overblown, and their rationale is that, well, if people with snakebite don't report, then it's probably dry bites and there's nothing to worry about. Because they think if you are envenomed, most likely you would show up in the hospital at some point, just that you may not get quality care. Do you think these perspectives are necessarily in tension, or are they both right? Is one of them wrong? Do you have an opinion on this, please? Thank you.
Thank you for that question, Mervyn. I agree, it's difficult to say whether it's over or underestimated. I lean more towards the underestimation because obviously people who don't present to hospital don't necessarily not present because it's only a dry bite or a light bite. All the neurotoxic envenoming, there was just a case in Southern Africa of a black mamba bite, and the person reached the hospital within 17 minutes and stopped breathing after that. These people don't reach the hospital if they're an hour away or 2 hours away, and not because they were lightly envenomed, but because they died before they got there. The same in Southeast Asia or South Asia with crate bites, which are not painful. People think, well, that wasn't an envenoming, and suddenly they stop breathing because of the neurotoxic envenoming. But the only way to answer the question, is it under or overestimation of the problem, is to improve the numbers. And as I showed, the numbers will improve by getting people to come to hospital to get assessed.
Thank you very much, Benno. We would move on to the next speaker. Just please keep your questions coming. Benno will answer them in the chat. We will also have an opportunity at the main Q&A session. So our next speaker is our colleague from Kenya, Ms. Valentine Musabimana. She will be speaking to us about some innovations in snakebite research and collaboration in Africa, with mainly a focus on the Kenya Snakebite Research and Intervention Center, which is hosted at the Institute of Primate Research in Kenya. Now, for those of us who registered a bit earlier, you might have noticed that we currently have a change in the speaker schedule because Dr. George Oluch, who was scheduled to speak, unfortunately couldn't make it due to an urgent shift in his availability. But still, we are in very good hands because Ms. Valentine is a research fellow at the Kenya Snakebite Research and Intervention Center, currently leading the antivenom quality control and development section at the center. And she has over 4 years experience in snake venom characterization and preclinical antivenom efficacy studies. Valentine is interested in the immunology and pathogenesis of infectious and neglected tropical diseases, as well as the treatment and prevention of these diseases through the development of effective prophylactic and therapeutic strategies. Thank you, Valentine, for joining us at such short notice. Over to you, please.
Thank you very much, Melvin. I'll be presenting. My name is Valentine Musabimana. I'm a research fellow at the Kenya Snakebite Research and Intervention Center at the Kenya Institute of Primate Research, and currently leading the Antivenom Quality Control, Development and Production Department. I'm presenting on behalf of Dr. Jojo Mondi, who is the lead at the Kenya Snakebite Research and Intervention Center. And my presentation is on the innovation in snakebite research and collaboration in Africa. So I'm giving a bit of disclaimer. The next image is graphic, so kindly bear with me. So I'll give a brief background on snakebite envenoming. So snakebite envenoming occurs as a result of the bite from venomous snake, or when a snake spits venom into the eyes. It was declared a neglected tropical disease in 2017 by the World Health Organization, making it a disease of public health concern. In Kenya, we have an estimate of 30,000 snakebite cases every year, resulting to 7,000 permanent physical disability and about 2,000 deaths. Over the in the past years, Kenya used to compensate snakebite victims up to 700 million per year, and as of the moment, antivenom is the only specific therapy present for snakebite. This antivenom are purified immunoglobulin from hyperimmunized animals such as horses and sheep. And despite the development and production of these therapeutic products, there's still limitation due to the high costs, the safety of these products, and effectiveness of the given product. So these issues also related to venom variation in venom composition, which could be caused by geographical locations of the states of the snakes, interspecies, intraspecific variation that cause a major problem to antivenom development. So to bridge this gap and to resolve this issue, there's need to test antivenoms that are marketed in the country. For Kenya, most of the antivenoms marketed here are not from Africa. They're mostly sourced from different countries such as India, Mexico, and at times we get some from Costa Rica. So there's also need to develop a new snakebite therapy to address the issue of antivenom safety. So in Kenya, we have about 140 venomous snakes, of which 13 are of medical importance. We have snakes that present with various clinical syndromes, such as neurotoxicity. Of this, we have the Dendroaspis species, the black mamba, the green mamba. We also have the non-spitting cobras, such as the forest cobra and Egyptian cobras. We have snakes that present with cytotoxic effects, such as the pufferder, which is the most widespread snake in Kenya and in sub-Saharan Africa at large. We also have spitting cobras, such as the large brown spitting cobra, the red spitting cobra that is pictured here, and the black-necked spitting cobra. And we have snakes that present with hemotoxicity, coagulatory-induced disturbances, such as the Echis species. These are carpet vipers. We have the pufferder, and we have the colubrid. This is the Espholidas typus. These are a few pictured on this slide. So to give a background on K-SRIC, K-SRIC was initiated as a project under the Kenya Institute of Primary Research in 2017 and is currently incorporated as a center under the Kenya Institute of Primary Research, which is now under the Ministry of Health. It has as objective to undertake multidisciplinary research activities leading to better diagnosis and therapies for snakebite, and also has to mitigate the impact of snakebites through extensive epidemiological research and community-focused intervention and the enhancement of public health strategies. It has 3 departments. This is the antivenom quality control, development and production, snakebite clinical sciences, and snakebite epidemiology, public health and community engagement. We have key partners. I would fail if I do not mention the key partnerships that we have. We are supported by the Ministry of Health. We have the African Snakebite Research Group, which entails the Kenya Snakebite Research and Intervention Center, Eswatini Snakebite Research Group, and the Nigerian Center for Snakebite Research. And we have a consortium, Scientific Research Partnership for Neglected Tropical Disease, that has the Liverpool School of Tropical Medicine, the International AIDS Vaccine Initiative, the Indian Institute of Science. And currently, we also have another consortium, the African Snakebite Alliance, that has Kumasi Center for Collaborative Research in Tropical Medicine, the Rwanda Biomedical Center, Eswatini Antivenom Foundation, the Liverpool School of Tropical Medicine, and the University of Global Health and Equity. So K-SRIC works with various partners and is under various consortiums to be able to develop measures that would counter the snakebite burden. I'd start by presenting on the first department and the work that we do under the antivenom development, quality control, and production. K-SRIC was constructed in 2018. As I mentioned, it was constructed from ground to be able to curb the burden that we have of snakebite in the country and regionally in the East African space. We have to seek approvals from the Kenya Wildlife Services as the snakes fall under their jurisdiction. And we constructed the herpetarium. As you can see from the images, this is just an image of our snakes that we house in the herpetarium. We have established a CD1 mouse breeding colony, and all these are snakes that we house in our herpetarium, and all of them of medical importance. So for the antivenom quality control, this is mainly important, as I mentioned, because the antivenoms manufactured in the country, antivenoms that are used or marketed in the country are from foreign, especially from Western countries. So the efficacy is usually limited, and at times the antivenoms market their products. The antivenom manufacturers market their products without efficacy data. So we opt to bridge this gap by carrying out quality controls so as to ensure the antivenoms marketed in the country are of efficacious for use in the community. So we collect snakes from endemic areas, different regions in the country to cover geographical variation, and also during mitigation of human-wildlife conflict, we get to collect the snake species. So this involves venom extraction. So when the snakes are brought into our herpetarium, we have veterinarians that care for them, that do routine medical checkup during quarantine before they're introduced into the different houses where we keep our snakes. So we carry out venom extraction, lyophilize our venom, and then carry out characterization of these snakes to look at and determine the potency of the different snake venoms that we have in the country, and also generate their proteomes. We also carry out in vitro immunological assays such as enzyme-linked immunosorbent assay and immunoblotting, and also in vivo ED50, median effective dose 50 assay to determine the efficacy and the neutralizing potency of the different antivenoms. So we aim to create venom standards for all the snakes of medical importance in Kenya. This is very, very important so as to also help antivenom manufacturers from outside the country to have a background on the snakes that we have in Kenya, and carry out preclinical quality control of every new batch that is introduced into the region. So this is just an image of the Venom collection and antivenom collections that we have. In 2017, in partnership with the Liverpool School of Tropical Medicine, we released our first publication on the antivenom efficacy, which actually revealed these deficiencies in the antivenoms marketed. So we aim to now carry out various quality controls because new batches are introduced often into the region. We also aim to develop antivenoms, as I mentioned. We are hoping to develop next generation snakebite therapies. The first project was titled Identification of Broadly Neutralizing Antibodies Against Snake Toxins from Animals Immunized with Venoms from Snakes in Africa, as the conventional antivenoms are mostly manufactured from horses. So we targeted baboons since these have that closest to humans and their genes, the antibodies would be easier to humanize. We also targeted cows as they have a unique repertoire of ultra long hit CDR that is able to bind to occluded and recessed epitopes, as well as camels that have a unique heavy chain domain, VHH, that also has odds of binding to recessed and occluded epitopes due to their small nature, as opposed to the conventional antibodies that are marketed currently in various countries in sub-Saharan Africa. This is to develop new approaches and new therapeutics for snakebite victims and develop antibodies that would be toxin specific. So we aim to develop monoclonal antibodies that are specific to sub-Saharan Africa. As you can see on the presentation, we have a combination of toxins both from Africa and India. So this is to have cross-neutralizing antibodies or for the snake species that we have in Africa. We are also currently in the process of developing antibodies that are specific to necrosis. The conventional antibodies aim most of the times target systemic effects. So we aim to also develop antibodies or monoclonal antibodies that can target necrotic-induced toxicity. This is under the Serpent consortium that involves partners such as IRV, LSTM, NSRIC, ESRIC, K-SRIC, and the Indian Institute of Science. So this is developed from camels due to their heavy chain domain, VHH nanobodies that can penetrate tissues. We are currently, we've currently received funding from the government of Kenya to develop antibodies to basically improve on the conventional antibodies. So by developing antibodies that would be safe, effective for use in the region. So we'd be doing this by using our specific venoms that we have after creating our venom standards. We also have the Snakebite Clinical Department. So this department is aimed at defining the pathophysiology of snakebite envenoming. So this is in order to basically guide therapy and diagnosis. This was done in Kenya at the K-SRIC Center and in Nigeria at NSRIC Center, trying to define the pathophysiology of saw-scaled vipers, puff adders, and spitting cobras and neurotoxic cobras. So this is also aimed at understanding the pharmacokinetics of venoms and antivenoms. So we've had to establish capacity and collaborate with different healthcare facilities in the different counties in Kenya. We also aim to develop diagnostic methods or tools for snakebite envenoming through lateral flow assays. So these are kits, and through DNA diagnosis by using PCR methods to try and and identify a snake that has bitten a patient, because at times you'd find victims coming to the hospital not knowing the type of snake that has bitten them, and this now poses a challenge on the treatment and management of the snake bites. Under the clinical science department, we also aim to carry out clinical trials. So Professor David Lalu from LSTM received a grant from Wellcome Trust and is the current clinical lead of the African Snakebite Research Group. And this is aimed at conducting clinical trials for antivenom efficacy. As it's known as of the moment, preclinical efficacy of antivenoms is the main method used to assess the efficacy of antivenoms. But we also aim to carry out clinical studies to look at the effectiveness of antivenoms, basically in humans, especially those envenomed by snakes. So K-SRIC is most likely to lead these clinical trials in Kenya because we have already established capacity. We have these monoclonal antibodies that we're in the process of developing against systemic envenoming, and also monoclonal antibodies against necrotic envenoming. We also have a public health and epidemiology epidemiology, public health and community engagement department. As I mentioned, it has as objective to mitigate the impact of snake bites. This is by establishing sustainable solution for prevention and control management of snake bites, as well as involving the community by carrying out snakebite surveillance, snakebite mapping all over the country, so as to address the issue of lack of data on the incidences, mortality, and morbidity of snakebites. So in partnership with we integrated with other entities through the Mass Drug Administration in partnership with the Department of Vector-Borne and Neglected Tropical Diseases, which is hosted under the Ministry of Health, and carried out survey of hospitals and households in each county. So this involved conducting and determining the incidences, the mortality and morbidity caused by snakes, and also looking at the availability of antivenoms and their cost in different healthcare facilities, and mapping snakebite cases and admissions in healthcare facilities. So this is just data collected from 4 counties, but we are currently in the process of collecting data of different countries, so as to have general surveillance and snakebite mapping data of the entire country. So we also we also carry out assessment of the socioeconomic burden of snakebite. So for instance, in this image, this is one of one of the team members that was carrying out household surveillance of snakebite socioeconomic burden in Samburu County. This is a county in Kenya. This is a recent publication by our PI, Dr. George, on the epidemiology of snake bites in nomadic population. So far, we have sampled 17 counties of 45 in the country and aim to collect data on different counties so as to inform policy. And we are also trying to map, we've mapped the impact of snake bite in livestock in partnership with the Ministry of Agriculture and Livestock. So this is also to generate data not only on humans, but also on livestock, as we have different communities of herders in the country. So it's very important to also look at the burden, the snake bite impact in livestock. So we also carry out the cost of snake bites. So when a patient is bitten by a snake and presents to the hospital, at times after bite, they incur several costs. So we are looking at the cost of these snake bites to patients, to different healthcare facilities, and the epidemiological patterns of hospitalization, mortality, morbidity, and disability-adjusted life years and quality-adjusted life years. We carry out community engagement. So the moment you educate the community, you're at least closer to reducing this associated morbidity and mortality. So we aim to educate the community on how to coexist with the snakes, because as we know, the snakes also are important to the ecology in controlling various rodents. So we aim to educate them on different ways of coexisting with snakes so as to prevent cases of snake bites, and also carry out first aid training to the community and various healthcare facilities, as well as going to deep community as shown on the pictures. We've also developed a system as Snakebite Emergency Response System to aid the community in combating snake bites in their respective counties. We've developed a motorcycle ambulance because snake bites occur in the most rural areas of the country and the county, where even ambulances are not able to access. So with something like a motorcycle ambulance that can reach even the poorest of the poorest in very poor roads, it's a measure that can mitigate and help reduce the burden of snake bites. We also train healthcare workers on how to manage snake bites. So far, we've managed to train 50. We've done 50 trainings and conducted in different counties, because oftentimes you find healthcare workers that are not sure how to manage snake bites. So with the help of K-SRIC, we've gone to different counties and tried to train these different healthcare workers on how to treat snakebite victims and manage snake bites so as to reduce associated snakebite morbidity and mortality. So this is a publication with our collaborators who who did their study in Kenya and are looking at the different perspectives of healthcare workers in the country. We also carry out advocacy. So this is to strengthen capacity and looking at the role, advocacy on the role of government to formulate different policies. For instance, we not only do advocacy at the higher level, we also go to the lower level where we have elders, we have chiefs that are closer to the community. At times, we have different communities that can only get information from their elders. So we get to the lowest, to the local administration that is able to get access to the common person in the community. We've also participated in the launch of the Kenya National Master Plan for the elimination of neglected tropical disease, which happened on January 13th or January 30th when we were celebrating the World NTD Day. And K-SRIC participated in developing the guidelines for prevention, diagnosis, and management of snakebite envenoming. So this is very important as K-SRIC is devoted to in creating efforts of advocacy to disseminate the need for research and sustenance in our research outputs. So these are just some of the few pictures showing the capacity that we've managed to build with our Ministry of Health. This is our cabinet secretary who visited the center, our permanent secretary visiting our center, and our Ministry of Health officials, as well as us going to educate the community about snakebite during the World Neglected Tropical Disease Day that happened on January 30th. So in summary, K-SRIC is aiming to work and basically try and reduce morbidity and mortality, following the goal of WHO of halving snakebite morbidity and mortality by 50% through creating safe and effective treatments. This is what we're doing when we're carrying out antivenom quality control, development, and venom research by empowering and engaging community through our various community engagement activities, creating stronger health system and partnership coordination and resources. So it wouldn't be fair for me to complete this presentation without acknowledging the various partners that have funded our work, the various collaborators that we work with. In a special way, I'd like to acknowledge the funders, the Department for International Development, K8, Wellcome Trust, the National Institute for Health Research, and also, I believe, one of the panelists, John Amwasi, who's from the Kumasi Center for Collaborative Research. We are in partnership under the African Snakebite Alliance, various county officials, and various centers that we've collaborated with. With that, I'd like to thank you for listening in. Thank you very much.
Thank you very much, Valentine, for that excellent presentation. I mean, I must say, K-SRIC looks very exciting with that excellent diversity from epidemiology work, community engagement, and higher-level molecular work, and even clinical intervention. I think the Ghana team will have to plan and visit soon again. So you want to take note.
Yeah.
I had a question for you, Valentine, but
yes.
I think there is a question from George Kirkham, which sounds more interesting, so I'll read that instead. George Kirkham, I hope I got the name right. He says, is there any evidence that keeping snakes in captivity can lead to changes in their venom composition? Example, due to changes in diet, meaning that antivenoms made from these venoms may become less effective in time.
Yeah, sure.
There's a double barrel to that question, but I think please go ahead and take the first part.
Yeah, thank you very much for that question. So I've not seen research that show that there's variation, but I believe that there's great variation when you keep snakes in captivity. For us, when we bring in snakes from captivity, we aim to extract the venom as immediately after quarantine, we carry out venom extraction. So this venom is what we use in the immunization, in the various laboratory and research work that we do. But of course, I believe that when snakes are kept in captivity, especially since you're giving them a different diet from what they receive in the wild, their venom might start varying. And these are studies that can be conducted to look at the variation of what we have in the wild and what we have in captivity. For us, since we have the opportunity to get snakes from the wild, oftentimes after keeping them in captivity for a while, we release them, but we also aim to look at that variation, which I believe exists because of the diet, because diet also affects venom variation. Yes. And the environment as well. Yeah.
Thank you very much for those clarifications. There's another part to this question, which I think I'll still take because it has some interest to John Amweti as well, I believe, because he's the co-chair of the Lancet One Health Commission. And the question is, how do you balance the ecological impacts of harvesting snakes from the wild with the need to produce sufficient antivenom. Would you have a response to this?
Also, we do not, I believe we have enough snakes in the wild for ecological purposes because they're basically aimed at controlling various rodents, and they're important in the ecosystem. So we always release the snakes in the wild. You can collect venom and venom regenerates. So once we've collected venom that we believe is enough for antivenom development, we release the snakes back to the field. The venom regenerates, so there's no way we'd deplete or basically the snakes that you have in the wild. Yes.
Okay, thank you. We're a bit pressed for time, so we'll go on to our next presentation, which will be delivered in the next 15 minutes by Dr. John Amoisi, and he'll be speaking on snakebite research and policy with some focus on Ghana. So Dr. John Amoisi leads the Global Health Department at the Kwame Nkrumah University of Science and Technology in Ghana. He holds a W2 professorship and is group leader of the Global One Health Research Group at the Venom Institute for Tropical Medicine in Hamburg, Germany, and also at the Kumasi Center for Collaborative Research in Tropical Medicine in Ghana. And Dr. Moisi's research involves both field epidemiologic and clinical studies, including clinical trials across Africa on emerging and re-emerging infectious diseases, antimicrobial resistance, and NTDs, including snakebite envenoming, just to mention a few. Dr. Moisi also co-chairs the Lancet One Health Commission and is an honorary visiting research fellow at the Nuffield Department of Medicine at the University of Oxford. Thank you very much, John, for accepting to speak today. The floor is yours, please.
Well, thank you very much, Melvin, for this opportunity. I'll just jump straight in. Want to say a big thank you to Benno and Valentine for the presentation so far. I think a lot of information has been provided. I want to appreciate all those of you who have joined the call as well. It's nice to see some attention being given to snakebite, given that it's really a very pertinent subject area, especially because we need to learn how to live with snakes. Eradicating snakes is not a good idea. It will do much more harm than good. And so ultimately we need to be aware that snake bites will be with us for a long time to come. And so in one breath, we try to prevent snake bites. In another breath, we try and make sure that we treat them appropriately, knowing that whatever be the case, there will be bites. And this brings to the fore the relevance of health policy within the discussion on snakebite envenoming, because the decisions around how we handle snake bites are taken at a very high level and they trickle down. So what is the relevance of health policy to snakebite envenoming? So you'd realize that snake bites have been a policy issue for several years, not just a policy issue, but also a political issue. And I always say that it's very hard to separate global health policy from the politics of the day. They really do go hand in hand, and you cannot separate the two. Snake bites are also now an NTD, and I'll come to this a bit later and what this really means. But just to show you how snake bites were once an NTD in 2009, then they got removed, and then they got put back again. That alone should tell you the level of contention there is around the relevance of snake bites. If they can come on the list, get removed, and come back on again, then it evokes a lot of questions around what snake bites are and why they are such a thorny issue. Again, for now, snake bite is back again, but you can see here in that shot the discussion I was having with Kofi Annan while he was alive, of course, and it's just a year before he died. And he was telling me about his personal interest in snakebite and why he thinks it's important. Suffice it to say, he was instrumental in getting snakebite back on the list of NTDs. Venom already spoke to this, so I'll not spend much time with it. But this is just showing the distribution or the known, so I say known distribution of medical important snakes. But the reason why I showed this is also to point out that in this day and age of climate change, this distribution or known distribution of medical important snakes will change over time. And we do not have our eyes constantly on the ball to be able to determine how quickly or otherwise this picture is changing. And what this means is, again, what are the policies we have around collection of data to understand distribution of snakes, which obviously has implications for how we go about policy around antivenom production, antivenom distribution in anticipation of numbers of bites and the kinds of bites, i.e. the kinds of snakes that bite people. It just shows that we are flying not entirely blind, but we are flying with limited vision. And this is not very good. This again, Benno showed, but what I want to draw your attention to here is the actual, at least based or perceived, based on the data available, decline in mortality from snake bites between 1990 and 2020. Now, is this really the case or otherwise? Well, the fact is that for almost all diseases, we've seen a relative decline in age standardized mortality rates. If you look at the GBD estimates, this is attributed generally to an improvement in socioeconomic status between 1990 and 2020, i.e. the proverbial argument that improvements in socioeconomic status are a tide that lifts all boats. Suffice it to say, the fundamental causes of diseases are actually poverty, and when poverty is tackled to some degree, it improves generally all diseases, and snakebite is no exception to that. There is a WHO strategy for prevention and control of snake bites. It's part of the 2030 roadmap for NTDs. It also captures this. Just to let you know that policy around snakebite has assumed a very high level, including a global one at the WHO level. It focuses on 4 things: empowering and engaging communities, ensuring safe and effective treatment, strengthening health systems, and increased partnerships, coordination, and resources. I'm going to pick these one by one and quickly introduce you to this. Just a little more on this. Tackles right from, you can see the 4 areas that I was talking about right there at the very bottom of the step, through to the full rollout and the expectation of impact on communities. And you can see that the ultimate, not the silver bullet, but the ultimate bullet is really making sure that we have a constant supply of effective antivenoms that reach people in good time. This is testament to the recognition that snake bites will be with us forever. And we're not looking to completely avoid snake bites entirely, because this will not be possible, because there will be human-animal interaction. But just to make sure that we can have antivenoms available and that people can access these as quickly as possible, access the right antivenoms as quickly as possible. A little digression I have for you, just to show you some findings from work that we've done in Ghana, looking at the distribution of snake bites. And what I want you to take away from this is, first of all, that the distribution of snake bites is highly uneven, even within countries. And this has implications for snake bite prevention policy and antivenom distribution policy. You can see clearly the Upper West region in Ghana, brightly colored red, showing a much higher distribution of snake bites, as opposed to other regions which may be very light blue in color, showing there are much less snake bites. Further on, you can see that snake bite also differs in incidence by sex, i.e. men are more likely to experience snake bites in Ghana than females. This is also a function of lifestyle, i.e. farming practices or farming and other practices that invariably expose more males than females to snake bites. So it's not a question of snake bites, snakes preferring men to women per se, but it's important to recognize that males are, at least in Ghana, at higher risk of snake bites than females. And you'd realize that this would also be the case in many other countries. Another important point, you'd see massive variations in snakebite incidents based on the location. where the savanna areas are more likely to experience more snake bites. So if you look across, at least in West Africa, the meningitis belt, so to speak, would mimic a snake bite, or snake bite would mimic the meningitis belt. So you could with some caution say that there is also a snake bite belt that might exist in Africa. Just again pointing you to the fact that data can give us important pointers as to how policy should be crafted around the procurement and distribution of snake bites across various countries. Furthermore, you see again seasonal variation in snake bites, and you can see clearly how there are less snake bites in January, February, and then you begin to see an astronomical rise, which stays the same for the months March, April, May, and June. Then you begin to see a slight decline. This is just a function of dry season, rainy season. Again, pointing out that if you have the data, you can make the right decisions, which can optimize the procurement and distribution of anti-snake venom so that wastage is also reduced, because of course these antivenoms have a shelf life, and you just don't want to be shooting blindly. You want to shoot strategically on a targeted way so that you do not waste resources. You can know when to purchase, when to stockpile, how to distribute. Here are a few policy considerations based on the knowledge that we have currently around snake bites. First of all, and again, this is in line with what I showed you from the WHO strategic plan, empowering and engaging communities. The first step is always, okay, what can we do to not only reduce, hopefully, the incidence of snake bites, but also to make sure that people are aware of what they need to do when there is a snake bite. Benno rightly alluded to how people can have a bite from a black mamba, or was it a green mamba? I can't remember very well, in the PDR. And within 17 minutes of the bite and arriving at the hospital, the person stops breathing and either dies or needs to be put in a ventilator, that is if one is available. So it tells you that this problem is multifaceted, and people being aware of what they need to do is so critical. And also people being aware of how best they can avoid snake bites is also critical. So enter your education, communication, training, and facilitation. You can never do without this. And you can see a nice publication which was done by one of our group members here in Ghana, who is being co-supervised by Imkeer, who's based at Liverpool and in Groningen in the Netherlands, and myself. And this paper is looking at community members and healthcare workers' priorities for the control and prevention of snakebite envenoming in Ghana. So something that can inform policy as well. Another important thing is ensuring safe and effective treatments. This is very key. The WHO has pointed this out. First of all, having that strong evidence base to inform the procurement and distribution, making sure that anti-snake venom is actually there, and then it is there wherever it is needed. In addition to developing more effective, more stable, longer lasting in terms of shelf life antivenoms that are stable in terms of heat, so that they can withstand different conditions, i.e. being very heat stable, can easily be constituted on, and most importantly, that they are as effective as possible. Now you would see here, this is a story from one of the major daily newspapers in Ghana, showing how the main hospital in the Upper West region had run out of snake bites, and this is the region that experiences the most snake bites, in at least snake bites per capita, and also actual number of snake bites in Ghana. You can see here in that region some work that we did revealing the presence of antivenoms from India for snakes that are not present in Ghana, and this was being marketed in the region. Just showing you again the problem that we have with regard to the import and distribution of ineffective antivenoms, ineffective in the sense that these are the spectrum they cover are snakes that do not exist in that part of the world. These antivenoms do not have the market authorization and so on and so forth. But some way, somehow they find themselves on the market. And also antivenoms that are not supposed to be for sale, that are supposed to be found for free in health facilities, some way, somehow finding themselves on the market for sale, and not for sale at low prices, but at prices that those who need them the most cannot afford. Again, pointing to the fact that policy interventions of a certain magnitude and level are required. I need to move a bit faster now, but I'll speak a bit to health systems strengthening as an important part of improving or reducing snake bites and outcomes from snake bites. The increased resources, I've spoken to this already, mainly the anti-snake venoms, and then having the information in an accurate and a timely way. Again, let me speak back to understanding the distribution of snakes and the exposures to snake bites, and how this can change so rapidly on account of climate change, how these vary by season, and therefore meaning we need to have policy that is constantly triangulating data with the procurement and distribution of anti-snake venoms, and having the appropriate personnel to handle this. This calls for increased partnership and coordination and resources, the data, the advocacy, the collaborations. And I'm really excited about Mr. Tripathi's presentation, which will be coming up, showing what is going on with local antivenom production and why Ghana has thought of this as being very important, not only to the country, but also to the sub-region as a whole. There was a question on the One Health implications of snakebite. Snakebite is perhaps one of those NTDs that provides a very strong One Health, has a very strong One Health impetus, simply because snakes are animals which bite humans. This interaction between humans and animals is going to be there for yet a long time. Eradicating or removing snakes is not an option, and would actually do more harm than good, as I already mentioned. So understanding how we can maintain that balance of living with snakes, recognizing that they play a critical role in ecosystems, and they do provide what we call ecosystem services. Understanding these services that snakes provide, optimizing these services while reducing the risk of snake bites, or ensuring that there is quick enough intervention when there are snake bites, is so critical. Obviously telling you that we need a One Health approach to understanding snake bites. Again, looking at reducing the incidence of bites and the trade-offs that comes along with that. There's been a lot of talk around of the provision of footwear to reduce the incidence of envenoming, because obviously if snakes bite and they bite the boots, then the venom won't get into the human being. But what does this really mean? The constant provision of these footwear, and ensuring that people do actually use this footwear, and really measuring what is the true impact of this strategy on the prevention of snakebite envenoming. Also looking at reducing poor outcomes. So yes, people will get bitten, but the poorer outcomes in terms of loss of limbs, loss of livelihoods. And we saw the really graphic pictures of necrotic arms and legs. And this can result very quickly. Some of these neurotoxic bites can result in the exposure of tendon and raw flesh. Within just a couple of days, you really have your whole arm, your whole leg at risk, just within 2 or 3 days. Just again, reflecting how this can so negatively impact on outcomes, and not just outcomes in terms of loss of limbs and loss of eyes, especially from the spitting cobras, but also the psychological trauma that goes along with this, which is being studied by a number of people as well across the continent. So this whole policy around antivenom procurement and supply becomes very critical. I've spoken to this already, but just I want to emphasize not just any kinds of antivenom, but making sure that this is produced to the adequate standards in terms of GMP, and also making sure that they are efficacious enough. Saw the presentation from Valentine about the work that has been done in Kenya, looking at the effectiveness of various anti-snake venoms and the kinds of results that they found. How many countries in Africa have done this kind of work for us to understand the distribution of anti-snake venom and how efficacious this really is. I'll skip this, and I will also skip that as well because of time, and conclude with these slides on some key WHO anti-snake venom policy recommendations. First of all, that in most tropical countries, the polyvalent antivenoms are what is being recommended. Again, if you put it in a more literal term, it's like saying that we recommend that we shoot with a bazooka just because we're not too sure of what we're dealing with. So if you shoot with some heavy duty arsenal, you're most likely to address whatever it is, while we figure out the best way of being able to be more targeted in our approach. Again, looking at market authorization for antivenoms, there's a recommendation that there should be a provision of experimental evidence or preclinical testing that these are really effective. We're very eager to hear from Mr. Tripathi what has been done in Ghana to make sure that what we are producing is truly effective enough. And then for national health authorities to organize independent preclinical efficacy testing prior to importation of antivenoms. But while this is true, and many countries do this, there's also the back door, making sure that the net is closed so that people do not, through the back door, bring in antivenoms which are ineffective. Finally, the need also for civil society organizations. And I can see Spring Gombe, who's a strong civil society organizer, is on the call. She's on the line, and I saw her introduce herself as a snakebite enthusiast. We need more snakebite enthusiasts who can understand the science, but also advise us scientists as to how our information should be communicated. And the African Snakebite Alliance, which I'm proudly a part of, together with George and several others, Imkia and others who I know are on the call, is again looking at how we can do better with communication. Bottom line, the data is needed. Data across the board, ecological data, distribution of snakes, and understanding the epidemiology and how this is changing over time so that we can keep our eyes on that moving target and not just be shooting at an identified target, forgetting that this target moves. So the constant collection of data is important. Otherwise, we will have poor decisions. Poor data, unreliable data will lead to poor decisions, even though these decisions are taken with the best intentions in mind. And this is just to say that we're running out of time, and we need to make sure that we're acting within time with the data that we have to make the right decisions to salvage arms, legs, lives, and livelihoods. These are just a few take-home messages from the presentation that I have made. I'd like to say thank you very much to the Global Health Network, to my own organization, the Global Health Infectious Diseases Research Group at KCCR, to the African Snakebite Alliance, which myself and George are a part of, and also to all other co-organizers of this webinar. Thank you very much. Back to you, Melvin.
Well, thank you very much, John, for this professorial delivery as always. And no surprise at all that you managed to sneak in the One Health approach. And my question, though, is not on One Health, but another important point you highlighted. The WHO policy recommendation that prefers polyvalent antivenoms in tropical countries, as opposed to monovalent, obviously for reasons like logistics and absence of RDTs. I mean, do you think this general global policy synchronizes well with the local policy and practice in Ghana? And would you say perhaps countries in the tropics should also be aiming at shifting towards making rapid diagnostics more available? Thank you.
No, thanks, Melvin. I just realized I'm having some connectivity issues. Can you confirm that you can hear me and see me?
Yes, you are visible and audible. Hello, John. I can hear you. You're back now.
I think we had some connectivity challenges. I think we're back now. So it's a great question actually you've asked, and I think if I may give the analogy, I think you alluded to it a little bit. Back in the day when there were no RDTs for malaria, and where there was a lot of under 5 mortality, especially in towns and villages from malaria, the WHO recommendation was that for a febrile illness, treat with an anti-malarial and also with an antibiotic. Can you imagine? That was it. But of course, that is no longer. Now we have the test to track and treat policy. We're actually trying to reduce the use of anti-malarials so as to limit the emergence and spread of resistance, given that now we have just the artemisinin-based combination therapies as our last and only line of protection, and so on and so forth. We currently have this bazooka approach towards snakebite treatment in Africa as a WHO recommendation. It is appropriate for the times we are in, but it also reflects the need for us to target our treatment, because when we are able to identify which snakes are biting people, we can give them the appropriate antivenom that would neutralize the venom and lead to outcomes. Currently, you can be delivering as much as between 1 and 2 vials for a bite from a hemotoxic snake, to delivering over 10 to 15 or even 20 vials of the same polyvalent for a bite from a neurotoxic snake. That's not good enough. So yes, the policy is good for now, but in itself reflects that there's a lot of work that needs to be done around appropriate targeted diagnostics, point of care diagnostics, not only to identify the kind of bite, but also to identify the intensity of the envenoming, which will also inform the quantum, or both the type and the quantum of antivenom that should be given. And I could go on and on, but let me stop right there. Hopefully we'll have more time for discussion on this.
Yeah, thank you very much. These clarifications are very good to address the seeming disconnect between policy and practice sometimes. Thank you very much for that. I'd like to remind all of you that we have some links in the chat which directs us to a survey asking us how we would want to be further engaged. I have just recently reposted one of them from the BNITM group, so kindly engage with that. Just before or during registration for this seminar, we posed a single question to our attendants on what their thoughts were on the top priority for Snakebite Research and Collaboration was. And of course, we had varied responses, but I just completed a quick thematic summary which showed that antivenom development and access was #1 on the minds of most people here today, even ahead of epidemiology and surveillance, community education and awareness, or clinical management and treatment. So I think this is very interesting and sort of sets the tone nicely for our next presentation. So I will invite Mr. Tripathi to share the screen whilst I introduce him to present on local solutions and manufacture. This will be our final presentation for today before the Q&A session proper. So Mr. Dhananjay Tripathi is a registered industrial pharmacist and entrepreneur. He's the dynamic CEO of the Pharmanova group of companies in Ghana and recognized as Pharmaceutical CEO of the Decade in 2021. He has led the company to numerous accolades for corporate responsibility and excellence, and his leadership extends beyond Pharmanova by serving as the Vice President of the Pharmaceutical Manufacturers Association of Ghana and Treasurer for the West African Pharmaceutical Manufacturers Association, starting in 1992 and climbing from the position of Chemist to General Manager in India and Ghana before founding Pharmanova in 2005. And under his guidance, the company has expanded regionally to Ivory Coast, where they've established Pharmanova Côte d'Ivoire and Atlantic Life Sciences Limited in Ghana, which is currently operating a CGMP compliance plant for various products. I could go on and on about his accolades, but for the purposes of time, just know that we are going to hear from a man who has demonstrated a commitment to reducing morbidity and mortality from snakebite, and indeed vaccine preventable diseases, because the company is into the manufacture of vaccines as well. And he is aiming to leave an enduring legacy in Ghana and the West African sub-region. So over to you, Mr. Tripathi, and thank you very much for joining us today.
Thank you very much, Dr. Melvin. giving us this opportunity to talk about the local manufacturing of anti-snake venom in Ghana. That's one of the challenge which we are facing across the Africa. So we would like to make presentation what exactly we are currently doing in Ghana, the West Africa. So local production and the homegrown solutions for the snake bite and how we can meet the challenges. So if we speak about the overview and the work what we are doing, we can say that snake bites is one of the emergencies across our sub-region in Africa. Ghana has currently 9,600 snake bites, which every year, the data is from 2015 to 2019. And antivenoms, generally it is supplied and covered under the National Health Insurance Scheme. And when we do the local production, the high cost of the antivenoms, what is currently available is close to $100 thereabout up to the branch what is available in the country. And currently we are importing these antivenoms for the solutions. Most of the time there is challenges for the supply because of the various challenges. And we see that as a local company, we can bring some kind of solutions when we are doing that local production. And I can say that we have several advantages as a company when we do local production in terms of the availability of the product in the country and in the sub-region and across the continent. And when we see the policy of the government, government is very keen to see that how best they can create an ecosystem environment for the local production of serums and vaccines. So our government has created a National Vaccine Hub Institute, and the function of the Vaccine Hub Institute to work with the relevant agencies in the government, with the academia, with the regulatory agencies, with the health services, Ministry of Health. And we can see that by this way, we can create a good local capacity in the country. And once we are able to do the local production, the supplies can be very easy. And in the area, the country also has put up provide like a solution to do the drone system, because many of the time the roads are not the best, and some of the communities which is waterlogged area, so the supply of some of these drugs are quite challenging. And government is very keen to work with academia and generate the more people in the sector, the professional who can be contributing to the sector. And by that way, we have a local team so that we can see how best we can localize that product made in Ghana. And we can also say there is a community awareness to see that how best we can have some kind of local talk and see that to synthesize to the public from the orthodox treatment, and that may also create sometime challenges, even the worsening in the treatment of the victims. So we want to talk about the importation to the local production in Africa. So Pharmanova is a company we started in 2000 to produce non-sterile products, and also was importing some of these vaccines and serums like anti-snake venom, anti-tetanus serum, anti-rabies vaccines, anti-rabies serum, and many other vaccines. So our company had been importing the anti-snake serum from a company called as Vince Bioproducts, and that company has been supplying these anti-serum to the many other countries in the West Africa, not only in Ghana. So we are supplying currently importing products and to see that the polyvalent anti-snake venom for the various region in the West Africa. So we can say that sometimes the supply is also not there. So we have taken the decision that Atlantic Life Sciences, how best we can produce some of these products. We started initially with the sterile product like large volume parenterals, small volume parenterals, ophthalmic preparations, anesthesia products, and now we have recently started local productions of the serums and vaccines. The plant is now ready, which is approved by the FDA, Ghana, and many other regulatory agencies to do the local production for fill and finish for the anti-snake venom and many other serums and vaccines. So the first line, what we have brought, which is now qualified, that can produce about close to 150 million doses per year. We have 2 lines, and after the commercial production of few of the anti-serums, company is also about to start for a local fill and finish for various vaccines also. So we can say that we have an area which has been fully qualified under the grade A and B, and the product what we are going to produce here, it is currently the lyophilized products, freeze drying, the product which we have been importing, just to ensure that it is stable at the room temperature, because in the interior area there are many of the places where the storage facility is not very good. But we are also planning to do the liquid type, because currently the government has provided a lot of support for the storage condition 2 to 8 degrees centigrade across the country after the COVID pandemic. Our facility is well resourced with the quality control, and we have all the sophisticated equipment what is needed to carry out the production as well as the quality control. So when we see the product, Atlantic Life Sciences has signed the MOU with the Wills bioproduct last year to do the local production. We are working. We have completed the technology transfer with the company. So we have installed very similar equipment what is there in the parent company in India. We have got a tech transfer in which experts has also come to see that how best they can support for the local production. They have also helped us to do the local documentation, and the company also did the transport to validation from the plant to bring the bulk to Ghana. And then after that, with the support of the regulatory agencies under their guidance, then we have started the trial batches in Ghana. So currently our production level, we have produced the fill and finish products. We are working for the potency testing. As on today, it is in the process now. The product what we are having, it is a polyvalent, that's 10 snake species, which is commonly found in Ghana and other West African countries. So apart from that, those polyvalent, what we are making, it has also paraspecificity for the anti-snake venom for the another 10 subspecies that we have defined, followed. Now we want to emphasize that what is the benefits of the local manufacturing, local production. One of the area we can see that when we do in the large scale, then the cost will be more competitive. Product will be easily available. It will be very accessible, because many of the time product is not available in the country, and accessibility is also very poor. And also we can say that we will have some kind of research activities. We can even make investments to see that how best we can collaborate with the academias, and then we can also get a better data in all the interior, all the regions and along the place. I was very happy to see that Miss Valentine's presentation for the Kenya, the good work what she's doing. So that looks like we have to do more collaboration to get more information and see that how best we can also do the local fill and finish and the type of the snakes and then the venom and the anti-venom, what we can do local production in Ghana. We can say that our regulatory agency in Ghana, we are having a level 3 recognition maturity level from WHO for the pharmaceuticals, and we are very close to get the approval for the vaccine production as well as serum production. So it will be very easy for us to do the local production and get support from the regulatory agencies from the country. As a country, we have got a very good image, so that when you produce made in Ghana products, it can be very easily recognized in many other countries. And we can also see that by local production, we can create a lot of employment. Currently, our company is employing a lot of people from the sub-region and from the many other countries, not only from Ghana. We can also say that by this way, we can also have the reduced mortality rate. And also, once we do the local production, we can see that falsified drugs and substandard drugs, that can counterfeit drugs, all those things, those challenges can be easily met when we do the local production here. Next slide. So we wanted to give a little brief about the equipment, our equipment, our quality control laboratory is fully equipped. You can see the equipment like HPLC. We have number of HPLC, atomic absorption spectrophotometer, UV titrator, gas chromatography. Then we also have a bacterial endotoxin test BET capacity, and we also are working to see that how best we can work with the local agency to do the subcontracting for the potency testing. That from the Center for Plant Medicine Research, Mampong, and also with the Noguchi. And we have number of partners, collaborator in this project, like National Vaccine Institute is there, which is under the government framework to give a good ecosystem to see that FDA regulatory agencies, then the USAID is also there to give us a support. Then the Ghana JET, then the PTB and the GIZ, and we are getting a lot of support from some of these agencies. But this collaboration is the different level from each and every organization. The next slide. So current engagement we are having with the NMIMR for the snake bite prevention and management, that we are trying to see how best we can collaborate. Also, we are also collaborating with the Ghana Medical Association to see that how best they can also give support to the product once it is made in Ghana. Of course, we have a lot of future plans which we want to see that how best we can work with the local 2 research institutions to organize like the snake bite prevention and management with KCCR for the northern sector. I can see Dr. John Amwasi has been doing a lot of good work in this area. We have to use his expertise, his team, even Dr. Melvin, the work what they are doing. So we are having plan to have a greater collaboration in the future. We can also say that Noguchi Memorial Institute, NMIMR for the southern sector, we are trying to see how best we can collaborate. Company also have a lot of land and for the future expansion of this project. And we are also trying to see how best we can have a animal experimentation facility for the potency testing. That the talk is going on with the company to see that how best we can plan to do that local here, local potency testing. So with this, I would like to thank you, all of you, to have a time to see that what we are doing. We are open to give any answer if you have any questions for the presentation. Thank you very much.
Thank you very much, Mr. Tripathi. That was a wonderful presentation, giving us an insight into the wonderful work that Atlantic Life Sciences is doing. Just to remind participants, I've seen quite a number ask whether the slides will be available. And yes, these will be shared on the Global Health Network platforms, and so that's something to look out for. But just one question for Mr. Tripathi before we move quickly into the Q&A session. I mean, one of the biggest problems, apart from physical access to antivenoms, obviously is the cost. And for us clinicians, we see everyday anecdotes about how one snake bite can drive a whole family into poverty. So we are a bit curious about affordability issues, you know, and you know, how will your product be like for our market, and whether this will be able to be sustainable in the long term.
You see, when we start the local production, that's one of the challenge at the very initial stage. What we have done, we have talked to the parent company who is supplying us the bulk to do the local fill and finish Ghana, to see that how best they can provide a very competitive pricing. And government is also very keen to see that how best they can provide all the needed support. Of course, initial stage, the cost may not be very competitive, but of course, we are trying to do what best we can do. But it's not only for Ghana. When we are going this local production, it is for the continent. As long as we do the local production supplies, the volume may be lesser. But when with the economics of scale, when we are able to do the production for the other countries, for example, the monovalent, which is required in the northern part of Nigeria, if you are able to do that product, maybe we can also see that how best we can increase our economics of scale. And I see that within a year, we'll be able to bring a very competitive price. So we have to see that how best we can patronize once the product is made in Ghana, in the other part of the continent. And we'll also try to see how best we can collaborate with various, like East Africa and the other southern African countries, to see that how best we can exchange our data information. And we will work together to see that how the other countries are able to patronize our product. And with this economics of scale, I'm sure that we'll be able to give the better pricing. And at the Africa CDC level, a lot of talks are going to see that how best we can support to the local company. So we have to see that how best we can look at that made in Africa. That's one of the concepts we should see. And with all the support, I'm sure we'll be able to bring a very competitive price made in Ghana or made in Africa anti-snake venom. Thank you, Dr. Melvin.
Thank you very much for the question. And Amelie Kakli, I hope I got the name right. Mr. Tripathi has answered your question simultaneously, so that's it. One of our panelists, Dr. Venom, has to leave soon because he has to attend another important meeting, I think in the next couple of minutes. So if anybody has a question relevant to his presentation or the opportunity he shared, I think now would be a good time to either raise your hand, and the technical team in the back would let us know so we can unmute you so you ask your question before he leaves. We have run a bit over time, and we expect to close in the next 13 minutes. Thank you very much for your patience. Okay, so whilst we wait for a question from participants, I mean, I was a bit curious about, you know, the potential for collaboration between the East African side and the West African side. And I don't know, between Valentin and Mr. Tripathi, when you guys were speaking, did you identify any commonalities or overlaps where you think you could collaborate? I did notice that some of the species are common to both regions, although of course geographic variations matter, but of course, we also are doing this so we can identify potential for future collaboration. So feel free to discuss any further points.
Thank you very much, Dr. Melvin. Miss Valentine presentation was quite impressive, very informative, and I can see that a lot of work is being done in Kenya. So I wish if we can collaborate as a local company here, local production, and anything what we can work together, the type of the species, what is there, and then antivenom, how best we can work together, because these encouragement will be such that we can expand our production for the polyvalent, what is there for the West Africa and for the other part of the Africa. I know that East Africa weather is not as the tropical weather what we have in the sub-Saharan Africa. So the need for us to see that how best we can collaborate. I wish to invite to the panelists to come and visit our facility. The facility is for serums as well as for vaccines. I did not mention, but we have done many of the collaboration in the area of the vaccines very recently for our TD vaccine from the Indonesia, then TT vaccine, then the pentavalent, then the hepatitis B, then the HPV vaccine very recently with one of the WHO pre-qualified plants. So looks like there's a lot of collaboration we can do, and then we can see that how best we can support each other. Thank you.
Thank you so much, Tripathi, for that. I believe collaboration is very key. So Dr. George would be the main person to address this, but I think and believe since he's part of this collaboration and this webinar, I think he'd be the right person to address it. But yes, collaboration is very key because we've also collaborated with various other institutions. And since you're trying to target an antivenom that is effective for sub-Saharan Africa, it's very important to have key partners in the different regions. Yeah.
Thank you very much, Valentin. We think it's very important to bridge the gap between science and industry. But just before, because Benno has to leave, I've noticed your hand, John. I would give him the final words if he has any, so that he can go for his meeting. And then, John, you can take over. Thank you.
Thank you very much, Melvin. I only like to say thank you for inviting me to this very interesting panel again. I learned a lot, and I'm really looking forward to seeing snake antivenom being produced in Ghana. And hopefully with the work we do together, we can actually help inform which snakes really need to be covered to be able to optimize the production of that antivenom. Thank you very much.
Thank you very much, Benno, and we appreciate your time with us today, and we'll talk soon. Thank you. Okay, John, over to you, please.
No, thanks. Just two things I wanted to speak to. One is collaboration within Africa around snakebite research. You can see obviously that the work that George and his colleagues are doing together with Valentin in East Africa, Kenya to be precise, is very advanced. And we in West Africa and even in Central Africa can have a lot to learn from what they've done in Kenya. I'd like to ask Valentin how they are ramping up to be able to share knowledge and expertise across the sub-region, so that the same kind of work that has been done in Kenya can be replicated, especially understanding the profile of snakes, potency of venom, and other critical pieces of information that would go a long way to inform the production and distribution of antivenoms. And then the other part would go to Mr. Tripathi, if he can speak a bit more to the GMP manufacturing of the anti-snake venom, because I know this is very important to the WHO and also to possible expansion of supply across the sub-region, and the degree to which they are open to collaborating, trying to look at conducting observational studies on the outcomes of the use of their vaccine here in Ghana, because this is what, again, this expertise that we can bring to bear when it comes to the research in antivenoms at this stage. So I don't know if Valentin wants to comment, and then Mr. Tripathi could also comment on my second question.
Oh, yeah, sure. Thank you very much, Dr. Amwasi, for that question. We aim actually to release and publish manuscripts detailed manuscripts on the work that we've done, so as to share knowledge across develop different methodologies and SOPs which you can share with different partners. And we also aim to collaborate, such as the Africa Snakebite Research Group, which had Nigeria and Eswatini. We hope to have so many people on board, probably through different collaboration, like the one that has been launched and the African Snakebite Alliance. So we hope to basically share knowledge, and I hope, I've seen Dr. George has joined the call. Maybe he can also help with answering some of the questions as the lead of K-SRIC. Thank you.
Hello.
Thank you very much. Yes,
Can
please
you
go ahead, Mr. Tripathi.
Thank you very much, Dr. John Amwarsi. This new plant which we have put up for the biological sections, it is meant to produce serums and vaccines. So in the first phase, we are making the anti-snake venom currently. Then is also going to do the other product also, and then the vaccines. So when you see the design of the plant from the day one, it has been done such that it has to go for the WHO pre-qualifications. The plant has been designed to produce vaccines also. Currently, WHO is not doing the pre-qualification PQ for anti-snake venom, but they are doing the listing. So we are in the stage where we have done local fill and finish, and we are trying to see that how best we can complete the other testing formalities, and all the activities is done into the current CGMP requirement. The plant is having all the sophisticated needed environment from the classification from A, B, C, D, what is required. There are about 2 to 3 people are working as a consultant to ensure that our plant becomes WHO pre-qualifications for vaccines and serums. We have done 2 mock study, our own requirement, the gap analysis, to ensure that by middle of this year, we are going to go to the WHO pre-qualifications. So we are having a requisite staff. We have a number of very skilled people and also very skilled scientists which have joined our company because of the vaccine plant. So we are trying to work under some guideline for the vaccine and serum production. So as per the plant is going to be fully WHO pre-qualified in the 2 years time. That's our estimation is. And along the line, when we do the local fill and finish, register the product, then we'll apply for the WHO listing for the anti-snake venom. We know that it is not only in Ghana. As soon as you plan to export the product, you need the WHO listing of the products. So that is in the pipeline. Our QA, quality assurance, and the quality control and the production team is working especially for the documentation and the environment currently. Thank you, Dr. John Amwarsi.
Thank you very much, Mr. Tripathi. John, I hope both questions have been answered. Is Dr.
Yes,
Olu
thank you.
still on the line? If he wants to say hello, George, we will unmute you so you could say hello to the house and tell us how it's going this week.
Good to see everyone.
Hello, George.
Yeah, I can hear you. Can you hear me?
Yes, we can hear you, George. Thanks for joining us at this time.
Yeah, thank you. I've not caught up with all the questions, but I'm sure Valentin has done a good job in answering them. But if there's anything particular you want me to talk about, you can please bring it up.
Right. Thank you. I think quite some interest has been expressed both during the discussions orally and also in the chat. At least I have seen one comment from a quality assurance person at Atlantic Life Sciences asking about potential future collaborations or engagement to the African Snakebite Alliance. And as co-chair of the alliance, I was wondering if you had any thing to say about that. Thank you.
Certainly. I'm really glad to see of the new developments in Ghana of a fill and finish facility. We've harbored such aspirations, and we've just been funded by our Kenya government to undertake local production of antivenom. So there's certainly many areas of collaboration. I did see some of the presentations from Mr. Tripathi, and the facility looks good. So you're certainly way ahead of us, really, in terms of setting up local production, quote unquote. So we've mapped out our snakes here. We've profiled the venoms, advising or improving the dose efficacy of the current antivenoms, and ultimately the affordability of them. So hopefully, like Valentin has said, just carrying out this health economics data and the value chain and the market access, of antivenoms in Kenya and West Africa, particularly in Ghana, we could share these protocols across and make sure that we're giving value or providing value for our people. So many areas of collaboration, as I've seen.
Thank you very much, George.
Thank you very much,
our maximum, I think, for today. We would like to show our appreciation to the audience for participating in the webinar, and we promise to remain in touch with relevant information and opportunities for professional development. We would also be grateful if you would give us feedback on the webinar by completing the webinar evaluation form. And to our distinguished panelists for sparing some time with us today, we thank you very much, as well as the organizing and the technical team. Thank you all for the excellent effort. And I think it's bye for now until we come into your inboxes or social media again. Thank you, everyone, and bye-bye.